Okay, this video is on disorders of the female reproductive system. So a quick review. There is the external genitalia, the vulva. The clitoris is analogous to the penis. It's erectile tissue. It's anterior and to the urethra. The vagina is the organ of copulation and the birth canal. It goes to the cervix. Picture we've all seen many times. I think the things to note are that the uterus is flexed forward over the top of the bladder here. The urethra is attached to the anterior part of the vagina, and the rectum is basically the posterior part here. Pubic symphysis is just down in front. The ovaries are just ever so slightly higher. There is two pouches in the peritoneum. The parietal peritoneum comes and then becomes the visceral peritoneum in this vesicouterine pouch here. It's a space between the uterus and the bladder. And then there is the rectouterine pouch of Douglas, here behind the uterus in front of the rectum. Those are both important places for endometriosis because they're blind sacs, as it were. The uterus is the organ where the fertilized ovum is implants and develops. The cervix is opening between the uterus and the vagina. The external os is opening into the vagina. It's filled with mucus. The internal os is inside. The fallopian tubes extend towards the ovaries, but they are not attached to the ovaries. So really, the female reproductive system means that theoretically the abdominal cavity is open to the outside. The only thing that's preventing microbes from entering the peritoneum is really the mucus in the cervix. The ovaries produce ova and the hormones, estrogen and progesterone. Breasts really should be part of the integumentary system, but they are considered in most textbooks with reproductive, so we'll include them here. They are mostly adipose tissue. There are glands that produce colostrum and milk for the newborns, but that's only when you are lactating. The rest of the time, they don't serve a lot of physiological function. Obviously, there is a cyclical nature to the uterus and to the ovaries. So there's a menstrual cycle in the uterus, and there is an ovarian cycle in the ovaries, and they have to match up. So in the menstrual cycle, the first few days are menstruation, the shedding of the endometrium. Then there's the proliferative phase, where the endometrial lining grows. Then there is the secretory phase, when the endometrium is secreting nutrients to nourish sperm that are in there, or nourish the oocyte or ova prior to implantation. Now, the ovarian cycle has to match up with this, and so the first part of that is the follicular stage, which is the maturation of the follicle, then ovulation, and then the corpus luteum development, so the luteinizing stage. In the ovary, the follicular cells that were once part of the follicle after ovulation become the corpus luteum. Before ovulation, those cells secrete estrogen. After ovulation, after the luteinizing hormone causes them to change, they secrete progesterone, progestation, for pregnancy. If implantation doesn't occur, then we end up with menstruation and the cycle starts over again. Typically, it's supposed to be 28 days, but it varies quite a bit from person to person. There was a point in my career that I would teach this stuff, and I was like, the natural thing is this 28-day cycle and blah, blah, blah. I was pretty adamant about it. And it is the way that it works. But then I came to this realization. I was reading a paper, and all of a sudden it was like, oh my God, that makes sense. Prior to maybe a generation or so ago, that's not what happened to most women. My great-grandmother had 18 kids that lived. She was probably pregnant 20 or 22 times in her life. And then she was breastfeeding for at least 18 years of her life, probably longer. And when you add that up, she started as a teenager with her first kid, Spencer, and then her last kid was my grandfather. She was probably either pregnant or breastfeeding from 1850, when Spencer was born, until 1889, when my grandfather was born. She didn't have monthly periods. She didn't have the menstrual cycle all that often, because she spent the majority of her adult life either pregnant or breastfeeding. And if you look at human history, that was probably more the norm. It's only been in the last 100 years, we'll say, and that'll be generous, that people get pregnant twice, or not pregnant ever, and that they delay getting pregnant until their 30s. That didn't happen before. So the normal kind of biological events were probably not reflected of this. I'm sure there was no menopause, because there was no chance that you were going to run out of follicles, because you were probably going to die before you ran out, because you just didn't ovulate all that often. Just throwing that out there. You've all seen these charts. If you want to go over them, I can put up videos about that, or you can ask me. I don't want to spend any time really reviewing this, but what this is really looking at is the ovarian cycle, what's happening in the pituitary gland, what's happening in the hormone levels from the ovaries, what's happening in the uterus, and this is temperature. And all of these things have to work together. There's a coordination. It's like it's almost like a piece of music. All the parts have to work together in order for it to work. Okay, so we'll start out with some structural abnormalities. So normally the uterus, like I showed in that picture, is anteroverted and anteflexed. So the cervix points posteriorly into the anterior wall of the vagina and slightly downward. It's held there by ligaments, but sometimes those ligaments get stretched, or they are not formed, or whatever, and we can have a retroflexion of the uterus. The uterus tips posteriorly. It might be curved, it might be completely bent over, but it's kind of can be all over the place. Now, if there's retroversion, it's going to cause really painful periods, dysmenorrhea. It's going to refer to low back. So low back pain is going to be significant. So so it can cause infertility problems. It causes back pain, dysmenorrhea, and dyspareunia. Dyspareunia is painful intercourse, and for obviously reasons. Like if the uterus is tipped backwards, then things are not in the right position to be comfortable. So a retroversion can be first degree, second degree, or third degree, where it is just tilted back like this. If it's retroverted and flexed, the uterus is bent properly. Retrocession is when the whole thing shifts back towards the rectum, and the vagina bends. If there's anteflexion, which is that it is flexed forward, not just displaced forward, but flexed forward onto the top of the bladder. Now, we can also have prolapse. So prolapse is when the vaginal walls become weak and they start to turn inside out. The vagina starts to be like a sock that's being taken off. So if the cervix drops down into the vagina, it's called a first-degree prolapse. If the vagina turns right inside out and the cervix goes all the way to the opening of the vagina and the body of the uterus is surrounded by the vagina, so the vagina is basically half inside out, that's called a second-degree prolapse. A third-degree prolapse is if the cervix and probably part of the uterus actually protrudes through the vaginal orifice. And so it starts to show on the outside. It's a third-degree prolapse. Problems with this is, there's some obvious problems, but discomfort, the possibility for infection increases with this. This normally happens if there's been multiple pregnancies and the ligaments are really stretched and the uterus isn't held in place. So there are various devices that are designed to be inserted in the vagina that push the uterus back up and hold it in place. Again, it's not something that a lot of people want to talk about, but is a very real problem in the elderly. Now, there's other abnormalities. Sometimes the rectum will protrude right against the posterior vagina. So this would be like especially if you hold your feces, you don't succumb to the urge. The pressure will build up and the walls of the rectum will stretch and it will actually start to protrude and push against the back of the vagina. Constipation, pain are the big problems with this. Sometimes the bladder will protrude into the anterior part of the vagina, and this is called a cystocele. Now, usually these things, what you try and do is surgically enhance the support of the ligaments and hold things in place. Now, occasionally, if there is especially if there's a lot of inflammation and infections, these things can cause adhesions. And adhesions can actually develop into fistulas. And fistulas is an abnormal opening. I had a patient for quite a few years. She was a very good patient. And she had a fistula because she had a rectocele. And then through inflammation, she ended up with a fistula. And her rectum opened into the top of her vagina. And she actually, when she defecated, it would not only come out of her anus, but it came out of her vagina as well. And she had to have that surgically repaired. And the repair didn't take, and there was, so she had a problem with ulcerative colitis as well, and so that was part of the problem. So she ended up having to have a colostomy bag in order to prevent this from happening. So there's the rectocele. Now this is from the other side from most of the pictures, but the rectum is pushing up here, and we have this retroverted uterus. The vesicocele is here, and it's happening because of the bladder. Menstrual abnormalities are very, very common. So the first one is called amenorrhea, without monthly flow, what the word actually means. It could be primary or secondary. So primary amenorrhea is probably genetic. It's probably something to do with inability for hormones to regulate, and so hormones aren't being made because of an absence of something. The ovary didn't develop or something like that. Secondary is from some hormonal imbalance. Now remember, the uterus is a different organ than the ovaries. And so an ovarian problem with hormonal imbalances, or a pituitary problem with problems of FSH and LH, will lead to menstrual abnormalities in a secondary form. Amenorrhea can also happen because of, it happens a lot in athletes that don't have a high enough % body fat to regulate these fat-soluble hormones. So it happens. Dysmenorrhea is probably more common. This is painful menstruation, and it's caused by prostaglandin release and maybe some ischemia of the endometrium, because the way that the endometrium sheds is ischemia of the functional layer of the endometrium, not the basal layer, and that can hurt. There's vascular spasm, that kind of thing. So you end up with cramping. Dysmenorrhea often starts before the period and will last into the period. Non-steroidal anti-inflammatories seem to be the treatment of choice, just management. PMS, premenstrual syndrome, is reasonably common, but it's not as common as the number of people that report having it. It's very gray area as to when it's actually the syndrome and when it's within normal limits. At what point do normal physiological reactions become abnormal? It's very gray. It happens usually a week before the onset of menses. It happens because the amount of progesterone being produced by the corpus luteum and the amount of estrogen being produced are both falling off. For after that, we don't really know what the pathophysiology is of it, but it's probably, on the uterus, it is a lack of support of the functional layer of the endometrium. But why it changes so many other things is difficult to know the physiology of it. It's probably got to do with the hormones and how they act in maintaining the homeostasis of other organs. Common is breast tenderness, water gain, water retention. So with that comes abdominal distension, some bloating, irritability, emotionally labile, sleep disturbances, headache, fatigue. It seems to be related a little bit to sodium balances and osmosis for the water retention. It changes blood pressure, things like that, so it can lead to the headaches and the fatigue. Treatment is exercise, watching salt intake, managing the change in hormones with oral contraceptives, the diuretics if the water retention is really high, antidepressants if the emotional symptoms or the depression are high. So it's basically symptom driven, any of the treatments. Abnormal menstrual bleeding is usually a hormonal imbalance or a problem with ovulation. It's something to do probably with FSH and LH affecting the ovaries and the hormonal levels being out of sync. So menorrhagia is an increased amount of flow. Raj is flow, and so it's like hemorrhage. It's monthly flow, so increased amount and duration. Metrorrhagia is bleeding between the cycles. Polymenorrhea is the cycles are too short and happen too often. Oligomenorrhea is not enough, so long cycles, more than 6 weeks long. And I don't know if there's one of these things more common than the other. Endometriosis is a very real problem. This is when endometrial tissue seeds outside of the lining of the uterus. So it's ectopic. And it will grow wherever there's a blood supply. So on the parietal peritoneum, on the visceral peritoneum, on the intestines, on the big place is that vesico-uterine pouch or the recto-uterine pouch, because the endometrial tissue ends up falling down there and colonizes there. The problem with this is this endometrial tissue responds to the cyclical hormonal changes. And so bleeding and spasm and pain happen anywhere in the abdominal cavity. But it's not supposed to happen here. So there's inflammation, and you can end up with scar tissue and adhesions, maybe obstructions of the involved structures. So like if it's around the small intestine, it could literally make it difficult for stuff to pass through the lumen. If it's on blood vessels, it can cause circulatory issues. There are probably 100 different theories as to why this happens. The one that makes the most sense to me from a logic point of view is a retrograde menstruation, as it were. So this tissue ending going out the fallopian tubes and into the abdominal cavity. But that's not established. And there's some theories that say there's a congenital defect and that tissue is outside all along. There are some theories that it is almost like a paraneoplastic sort of thing, where epithelial tissue mistakes what it's supposed to be and just starts to establish itself. And there's probably all kinds of other multifactorial ideas. None of them are actually proven. None of them really are the forerunner. So we're going to say that it's idiopathic. We do know that treatment is by hormonal suppression, which has its own problems. So oftentimes it's birth control pill is how they do it, or surgical removal of this ectopic tissue. And so they often do this laparoscopically with a laser, and they cauterize, they burn this tissue off. The problem is finding all the spots, because they could be anywhere from the diaphragm to the pelvic floor. And to be thorough about it, to be effective, it's very difficult. So there's probably a lot of failures of this surgery. Some of the more common spots are right behind the umbilicus, because there is a ligament there that used to be a blood vessel, anywhere on the peritoneum, on the ileum, not necessarily just right at the ileocecal valve, but anywhere on the ileum. Very common on the outside of the uterus, on the colon, in the pouch of Douglas, so the posterior pouch, or like the rectum uterine pouch, or in the vesicular uterine pouch. Those are common places for it. Yeast infections, fairly common. It causes vaginitis. It's not necessarily sexually transmitted. Candida albicans is the opportunistic thing. There's supposed to be a little bit of yeast there, so it becomes its normal flora. It becomes opportunistic for a lot of reasons. One of them being antibiotic therapy. So antibiotics to fight other problems killed off the flora of the vagina, especially the lactobacillus, and that leaves space for the candida to flourish. One of the things that happens in the vagina is that lactobacillus, which is the same bacteria that they make yogurt or kosher dill pickles with, is it's a bacteria that has no mitochondria, and so it's an anaerobic bacteria. When it makes its ATP, lactic acid is the byproduct, and that's why it's called lactobacillus. And it makes the vagina acidic, so it lowers the pH. And acid is not hospitable to most bacteria, and so, or yeast or anything else. So it controls the amount of flora that's there. Antibiotics can kill that off, and then that becomes a problem. Pregnancy can sometimes do it. Diabetes definitely, because the amount of sugar that comes in the urine is a medium. Reduced host resistance, so anything that makes you immunosuppressed can cause it. It causes red, swollen, and itchy membranes, and a discharge that is cheese-like. It can extend right out into the labia, the vulvar tissues, and the treatment is an antifungal treatment, Canesten. This is an important one, pelvic inflammatory disease. So this is an infection of the uterus, the fallopian tubes, and or the ovaries. So this is the internal genitalia. It can be acute or it can be chronic. It's inflammation. Usually there's an ascending infection from the vagina or something like that. It's usually bacteria. It can come from blood-borne bacteria, so bacteremia. Most of the infections are sexually transmitted diseases, so this would be gonorrhea and chlamydia being the big ones for it. Non-sterile abortions, so backroom abortions. Childbirth can do it. It becomes an ascending problem. So bacteria, if they can get through the cervix, and so if it's causing inflammation of the cervix, that inflammation will water down the mucus plug. The organisms can get into the uterus, into the fallopian tubes, into the end of the fallopian tubes, and then out into the peritoneal cavity, and can be quite dangerous. I don't know why they have this IUD with adhesions to the IUD in this photograph, but I think they're trying to say that IUDs maybe lead to this. The biggest problem with this is that if you end up with inflammation that becomes fibrotic, so scarring of the fallopian tubes, those tubes can get blocked because the lumen is only the size of a hair, and can lead to infertility issues. Or it can lead to ectopic pregnancies, where the sperm might be able to get through a stenosis, but the fertilized ova can't, and so it stays in the fallopian tube, and it can implant there, so you can end up with ectopic pregnancies. The important acute complications would be peritonitis, infection throughout the abdominal cavity, abscesses, like pockets of, well, you know what an abscess is, or septic shock, where blood pressure and things change, and that can be life-threatening. Now, there was a problem once upon a time with pelvic inflammatory disease, because when tampons were first introduced, they didn't come individually wrapped. They came with the cardboard applicator, and they came like in a box, all of them open. And when you opened the box and you used, it was probably fine. But then where did people store the boxes? Probably in the bathroom. And who knows, you know, how many months would go by before that box would get used up. And so they weren't sterile. And so Tampax actually, I think, was sued, a class action suit, because of some of these complications, peritonitis and septic shock, from being a cause of pelvic inflammatory disease. I'll be honest with you, I vaguely remember this being in the news, but I don't remember any of the details. It's just kind of coming to me as I'm talking about this. But it is the reason why now they are each individually packaged. So pelvic pain is the first sign. Then you get some purulent discharge, leukocytosis, so white blood count goes up, systemic things like nausea and vomiting, fever, that kind of thing. It requires antibiotic therapy. It's usually in the hospital, and one of the big problems is that this all happens in the lumen, which is actually outside of the body. And so it's very hard for the immune system to get at this because it's not inside the body. And that includes the peritoneal cavity. But and because the possible consequences are pretty dire, it requires an aggressive therapy. A very common thing, especially in older women, is something called fibroids, leiomyomas. These are benign tumors of the myometrium. And that's the muscular layer of the uterus. Some of them are right next to the endometrium, and they can cause bleeding in the endometrium. Some of them are localized right in the myometrium, and their big problem is the space they take up. And some of them are close to the epimetrium, like on the outside, like the visceral peritoneum, and they can cause bleeding into the peritoneal cavity. They usually are really well-defined masses. They don't invade. They're not encapsulated, but there's a defined border of them. Like I say, they can cause bleeding. There's an awful lot of reproductive aged women that have them, that don't know they have them because they're not very big, and they're not causing abnormal bleeding. They're often treated hormonally, and again, this has got to do with estrogen, progesterone, affecting the development of the myometrium. If they get big enough that because of the space they're taking up, then surgery is an option. Sometimes the surgery is pretty radical. It's just full-on hysterectomy. Especially a few years ago, hysterectomies were very common. It was almost like, well, you're done having kids. Why don't we just do a hysterectomy and get this over with? The joke was, you take the crib, but you leave the playpen. And an awful lot of women, especially of my mother's generation, underwent hysterectomies for no real good reason. So, if it's just below the peritoneum, we call them the subserosal. If they are close to the endometrium, we call them the submucosal. Here, some of them can be polyps, but you'll see. So another is benign, is an ovarian cyst. There's all kinds of different types. Some appear, last a couple of months, and disappear. They're often multiple. They're fluid-filled sacs. Not very many of them bleed, but if it does, they require surgical intervention. They're usually identified with ultrasound, sometimes with laparoscopic investigations. Some people have a more chronic case and multiple, so they call it polycystic ovarian disease, and it's thought to be hereditary. The biggest problem with polycystic ovarian disease is that the capsule thickens around each follicle, and so it prevents the bursting of the follicle, and so there's no ovulation. But the Graafian follicle fills with liquid and becomes a cyst at this point. And this throws the hormones way out of kilter because you don't end up having a corpus luteum. And the normal cyclical arrangement of estrogen gets screwed up as well. Sometimes the estrogen, because the estrogen is first secreted as really an androgen that gets converted, and so oftentimes it just gets to be too much and it doesn't convert, and so you start to get male secondary characteristics, especially facial hair. Amenorrhea is a common problem because you don't get the progesterone levels going up and then falling off, and the estrogen levels don't fall off. It can be very difficult. So not only is there amenorrhea, but a lot of these women get very self-conscious about developing male secondary characteristics, especially facial hair. Arm hair gets coarse and thick. I know I probably know 15 or 20 people that have this, that have talked to me. Some of them students, most of them patients, and almost to a woman, they report huge libido issues, like really strong libidos. And again, that becomes societally difficult. Treatment is sometimes pharmacological, sometimes it's surgical, and sometimes it's just supportive. This cyst here is a dermoid cyst. Those are the ones that I showed you pictures of in previous lectures with teeth and hair in them. It's still a benign tumor. The biggest problem is the space they take up. This one, as you can see, is huge. The uterus is the size of a walnut. This is the size of an orange or a small grapefruit. The normal ovary is this little tiny thing over here. So look how much it's growing. Okay, well, we're talking about benign tumors. Fibrocystic breast disease. So this is nodules or masses in the breast tissue. It's usually cyclical. They wax and wane with the hormonal cycles. They may be precursors to breast cancer. They increase the breast density, and so that makes either self-exam or breast exam difficult. Hard to feel lumps when there's lumps everywhere. Caffeine has a marked effect on them. Okay, now we're into the malignant tumors. So carcinoma of the breast is way more common than we hope it would be. Incidence increases as age increases, with most in women over 50. Most of the time they're unilateral, they're in one breast. Earlier onset, so if you have it at age 25, it's probably a more aggressive cancer than if you have it at 66. They tend to be epithelial in nature, so they arise from the ductworks, the epithelial cells that line the ducts. They don't really necessarily come from the fat or the connective tissue. Big problem is there is a lot of lymphatic drainage of the breast, and that's the way that they seed. So metastasis occurs via the lymph nodes, and it happens fairly early in the disease. So you can go to stage 4 very quickly. Some people have estrogen and progesterone receptors in their breast tissue that's more than average. And if those receptors are found in the tumor cells, then treatment becomes much more aggressive. There's a genetic factor, genetic predisposition with BRCA1s and 2s. Angelina Jolie found out she had this predisposition, so she had a prophylactic mastectomies because she wanted to avoid it. Exposure to estrogen seems to be a a problem. So people that are nulliparous, so never had a child, or late in their first pregnancy, seems to be a predisposing factor, and that's probably because of the amount of estrogen versus the amount of progesterone. Lack of exercise, smoking, high-fat diet. Radiation will cause mutations and cause that to happen. Cancer elsewhere seems to be a predisposing factor as well, but it's not necessarily metastasis. Usually they're found on mammograms or by palpation, a hard nodule. The problem with that is they have to be fairly large before they're palpable. If it's gone on for a long time, there's adhesions to the skin, so as you lean forward, the skin will dimple in a spot, or there can be discharge from the nipple, because if it's in the ductal epithelium, those ducts go to the nipple. Most get a needle biopsy or ultrasound to confirm, but it's usually the needle biopsy. So we have these screening programs with mammograms that are looking for early signs, because the earlier you find it, the better. Usually there's metastasis 1 to 2 centimeters in diameter. That's pretty small. So what they do is, in the course of treatment, they look at the lymph nodes, because the axillary lymph nodes are the first ones involved. And then it will, via lymph, it will metastasize to bone, lungs, brain, and the liver are the big ones. And this is just a chart showing how it gets to the lungs, etc. So you hope to catch it early and have a lumpectomy. If it's larger, we can move with full mastectomy. Lymph nodes get removed because they biopsy them, and if they are found to have cancerous cells in them, then they get removed. This can lead to lymphedema, the one arm swelling quite a bit. We look, they're all biopsied, so they look for growth factors, and those factors will design the treatment. Radiation therapy to shrink the tumor before it's surgically removed is very common. Chemotherapy after to prevent metastasis. So you stage it, and you look for presence of growth accelerators, read estrogen and progesterone. Another common one is cervical cancer, usually caused by an infection of HPV, which is genital warts. There are now vaccines available against HPV. We won't get into any anti-vaccine discussions in here. This is why you do routine pap smears to look for treatable parts of the disease. Most women undergo pap smears, especially sexually active women. It's routine and it's important. So the epithelium lining the vagina has to be a stratified squamous epithelium because it has to resist abrasion. And because it has to resist abrasion and it's stratified squamous, there are no goblet cells, so there's no secretions, and so there is no lubrication. So there are glands in the vaginal vestibule that secrete mucus. The bulbourethral gland of the penis secretes mucus to give the initial lubrication, and the cervix secretes mucus to make the mucus plug, but also to lubricate during intercourse. The problem is that to have the goblet cells to make the mucus, the cervical epithelium has to be columnar epithelium. And so there has to be a place where that changes from stratified squamous to a simple columnar epithelium. And because of inflammation and because of irritation, that can undergo changes, as we talked about last course. And so as those epithelial cells undergo changes, then we end up with abnormal cells. And that's what we're looking for in the pap smear, is these abnormal cells that might be precancerous. So you get this dysplasia that's caused by a loss of differentiation caused by chronic or recurrent irritations and inflammations. If a tumor develops from these dysplastic cells, it first is in situ. So it's on the mucosal surface of the cervix. And then it will erode and invade into the submucosa, and then it will invade into adjacent organs like the walls of the uterus, or maybe into the rectum or places like that, and then it will seed by metastasis. We hope that it doesn't get that far. If you're catching it early in situ, treatment options are very good and prognosis is very good. If it's metastasized, then prognosis is far worse. So the normal transition zone to the cervix gets exposed to irritants. Now, one of the things that ejaculate has in it is prostaglandins. The male secretions have lots of prostaglandins in it because when the sperm is deposited at the cervix, the energy requirements and to get the sperm through the cervix, they need to get through that mucus plug. If there are prostaglandins, that causes inflammation of the cervix, which waters down the mucus and makes it easier to go through. Now, at about the time of ovulation, there are hormonal changes that means that the cervical mucus plug is a little less viscous than normal, and so that's how the sperm get through. And then the sperm are nourished by the secretions of the uterus on their journey up to meet the oocyte. But nevertheless, the prostaglandins will cause inflammation. So if there is lots of that, especially multiple partners, because everybody has different generators of inflammation, we can end up with this irritant exposure. Or it could be a carcinogen, could be genital warts, probably all of the above. So we end up with some mild dysplasia. If we find that on a pap smear, then we can intervene, remove the irritant, remove the genital wart, do various things for it. Just give it a rest and the DNA will repair itself. If the dysplasia is severe, then the dysplastic cells can become a neoplasm, become carcinoma in situ, and then invade, and then metastasize. So this is a fairly large tumor. You can see it's almost 4 centimeters. So, risk factors. Young age is it. You notice it's less than 40 years. So this is not a, this is no longer a baby boomer's problem. This is under 40. There's a strong linkage to HPV infections, multiple partners, a lot of years of sexual intercourse, other STDs, and for some reason smoking. So it probably has got something to do with nicotine and immunosuppression. In the uterus, postmenopausal women get carcinomas. Age over 50, oftentimes it's women on hormone replacement therapy, people with diabetes, people with obesity are risk factors. Spotting, vaginal bleeding seems to be more the indicator. Postmenopausal women become far more acutely aware of spotting than women in their reproductive years, because vaginal bleeding is not that uncommon in the reproductive years. Pap smear doesn't detect it because pap smear is sampling the mucosa of the cervix, and this is in the uterus. It's glandular epithelium, so it's a carcinoma. It's slow growing. It tends to be invasive. And surgery is the treatment of choice, usually hysterectomy. But if they suspect metastasis, then they might take chemotherapy. It tends to be invasive rather than metastatic, though. So radiation to shrink the tumor sometimes works if it's small. Wouldn't be a pathology course without gross pictures, so here you go. Ovarian cancer is a silent tumor. There are very, very few signs or symptoms of it, which means that it is very dangerous, because usually you're already at stage 4 metastasis before it's found. Sometimes it is detected by pelvic examination, but it would have to be huge. Transvaginal ultrasound is a way that it can be visualized, but again, that's not something that most people would opt for. They have to be looking for something, and there's not a lot of signs and symptoms, so they don't go looking. There may be some serum markers, some blood tests, but who knows? They vary in aggressiveness. Right? Risk factors are obesity, this BRCA gene. So it's got probably something to do with receptors for estrogen. Early menarche, so first periods being very early. Nulliparous, or late first pregnancy. Use of fertility drugs are all risk factors. If you look at this, it's a lot of the same risk factors as for breast cancer. It seems to be a problem of estrogen, because estrogen will stimulate follicles and growth within the ovary. Progesterone slows that, stops follicular development. So progesterone seems to help. So usually just remove it. Infertility can be both male or female conditions, combination. Oftentimes it's hormonal imbalances, so pituitary problems, FSH problems will lead to no follicular development in women, no sperm development in men, so low sperm counts. It can be because of structural abnormalities, infections, workplace toxins. Most of them are idiopathic. Yeah, we just kind of leave it at that. So STDs. I hear that you talk a lot about STDs in your program, so we won't spend very much time on them. Chlamydia is very common. Chlamydia literally means cloaked because it's hidden. It's usually asymptomatic in women, unless it causes pelvic inflammatory disease, or we're investigating reasons for infertility. Women with it can infect newborns, especially through the eyes in the birth canal. In men, it causes urethritis and epididymitis, so a white discharge from the penis, painful swollen scrotums, tenderness along the testes, along the epididymis. Inguinal lymph nodes will swell up. Burning during peeing, and itchiness. Gonorrhea is caused by Neisseria gonococcus. The biggest problem with these is the resistance to antibiotics. Usually the infection is in the urethra in men. Big problem is that some are asymptomatic. In women, it can be asymptomatic. And anything that's asymptomatic is at risk for spreading. And like chlamydia, pelvic inflammatory disease, and infertility are complications to gonorrhea. Again, it can affect the eyes of the newborn, so it's a lot like chlamydia. And the biggest problem is it can cause blindness. Up until recently, it was mandated that newborn babies get silver nitrate drops in their eyes to prevent this, to kill any gonorrhea that they're getting by passage through the birth canal. It seems much more humane to screen the mothers for gonorrhea and deal with it. But those laws were enacted before there were effective antibiotics, and gonorrhea was a much bigger problem. Another problem with gonorrhea is that it can become part of a triad of reactive arthritis, which is a systemic arthritis, kind of an autoimmune arthritis, that passes through the body. It's usually got to do with conjunctivitis and urethritis, often gonorrhea, sexually transmitted diseases. Here's just a chart. You can read about syphilis, primary, tertiary are the big things. Herpes is the herpes simplex 2 virus, which we've already talked about. Genital warts, which we've talked about. Trichomonas is a protozoan, so it's not bacterial. Here's gonorrhea in the epididymis. So syphilis is a spirochete. The only major spirochetes are syphilis and Lyme disease. At first you get a canker at the site of infection, so usually the genitals, but it can be the anus or the mouth, depending on activity, I would assume. It's a firm, painless nodule that ulcerates, the center of it dies, and then it heals, the lesion heals. It happens 3 or 4 weeks after exposure. You get this canker sore, and then it heals and it seems to go away. And so you can see the canker here, right there. If it's untreated, then you get systemic things. So you get a rash and flu-like symptoms. It's self-limiting, but you're contagious. Then it passes into this latent stage, which is still transmission can occur. And then you go to the tertiary, and you end up with these growths called gummas in organs and in the blood vessels, and it can lead to dementia and motor disabilities. The dementia can be quite marked. It can be transmitted to the fetus. If there's tertiary syphilis changes, it's not reversible. The brain doesn't develop properly. Antimicrobial drugs deal with it. We're worried about antibiotic-resistant strains becoming more prevalent. Herpes is similar to HSV1, so you get blister-like vesicles on the genitals. Can be painful, tingling, itching lesions. So you have the acute stage, and then the virus goes back to the dorsal root ganglion in the spinal cord, and then stays there latently, and then comes out at times of stress or physiological or psychological stress. When the lesions are painful, it is easier to spread. There are a lot of people living with it that have normal sex lives. They just have to be very careful when lesions are present. Here's some pictures of the lesions. stress and illness. So antiviral drugs are used to prevent transmission, but it's a lifelong infection because you can't get it out of the dorsal root ganglion. So genital warts are caused by HPV, usually asymptomatic. They get removed, often they're frozen off, cryotherapy. The biggest problem is predisposition to cervical cancer. Trichomonas vaginalis is a protozoan. It usually asymptomatic in men. In women, flare-ups, it's itching. Treatment is necessary for both partners, and it's systemic with antimicrobials. We're seeing that one of the problems here is a lot of these things are asymptomatic, especially for men, and more maybe for women in the case of chlamydia. And so they are much easier spread this way.